So you hear a pregnant woman calling, saying, sister, come and help. Let's go to mom and ask mom what's wrong, and she'll be able to give us advice. So here's the mother-in-law saying, go and ask your grandmother. She probably knows what's going on. And grandmother says, well, we never had all these problems when I was growing up. And so they're like, well, for accurate health information, call this, subscribe to Aponjan and get correct messages about your health. And take care of your mother and baby, subscribe and learn more about health. And so that's the Aponjan message. But today, we're really privileged to have both colleagues from the MAMA team in DC, as well as here our own Radha Rajan, who's a second-year DRPH student in HBS. And she's really been interested in mobile technology and health communication programs. And I think it was about a year ago, we had this opportunity to really work closely with the MAMA team on developing the findings of their formative phase research in Bangladesh, known as Aponjan, which means dear one. So it's someone sort of near and dear to the person. And so we began this journey with the team in Bangladesh, who is spearheaded by this NGO called DNet. And the result of that is this light reading document that we're going to go through today. I think we'll start with page 1 and go through page 193. But it's actually single-sided, so it's actually a little thinner than this. But I think what it represents is a really nice marriage between the program world and the research world, and thinking about how can we rigorously assess data that comes out of the program arena so that we can come to some conclusions that help us build better programs moving forward. And I think one of the great things in the mobile health space is that there is that opportunity to be both programmatically exciting but also scientifically rigorous. So without further ado, let me welcome Radha Rajan. And I'll also ask our two guests from MAMA to just introduce yourselves as well.
Yeah. Hi, I'm Tara Morzini. I'm a research associate with MAMA.
And I'm Josie Manlava. I'm the M&E officer for MAMA. We're both based in Washington.
Well, thank you all for coming. I really appreciate it, and I'm excited to be able to talk to you a little bit about the formative research findings from Aponjan. So I'm just going to dive right in. I think that Josie and Tara will talk a little bit about this, but MAMA is a broad partnership of public and private partners, so this is kind of a snapshot of, in Bangladesh, the wide variety of partners that are involved in the program. And to give you just a little bit of orientation to MAMA, it's a public-private partnership. They leverage these rapidly expanding mobile networks, connecting pregnant women and new mothers and their families, so people called gatekeepers, mothers-in-law, husbands, to age-appropriate, stage-based health information. And it was initially launched in 3 countries, Bangladesh being one of them. So I will focus on the Bangladesh program. And it is called Aponjan, as Alana mentioned, that means dear one or close one in Bangla. And it builds upon some existing health information from various government sources. It's implemented by DNet. They're a nonprofit organization in Bangladesh, and they have a particular expertise in digital content development. And there are a number of partners, and I'm actually going to focus a little bit more on this later in the talk, but a number of community-based partners that helped with enrollment in the program and kind of publicizing it to people across the different regions where the formative research took place. So the objectives, there's several objectives to the MAMA program overall, and the formative research was really looking at just a few of these. So the formative research was kind of focused on the sub-objective 1.1, which was looking at how to boost enrollment, as well as objective 2, looking at the effectiveness of the service in terms of the technology platform and user satisfaction, and then also looking at Objective 3, which was about building and managing partnerships with the various organizations that were helping with enrollment. Although the report didn't focus on this Objective 4 about looking at the business model and the pricing models, there was some pricing model information that was kind of taken into account for user satisfaction in the program. And then broadly, looking at this Objective 1 and kind of achieving knowledge, attitude, and behavior change in the subscriber base was something that they were interested in assessing within this evaluation, but it was much less of a priority as compared to the other factors. So I wanted to give you just a little orientation, a snapshot of the research activities that were associated with the formative phase. It was a 9-month phase from September 2011 to May 2012. And there were a number of different activities involved. I'll recap some of the main research activities in a slide or two, but it was quite an endeavor. And I think that this timeline is actually, it's one of 3 slides, and I just decided to show you one, but just to give you a sense of the number of different activities that were going on and were managed by DNET. So it was quite a challenging program, and really pretty novel in the fact that not something of this size and of this scope hadn't really been done before. The thing that I didn't capture here is there's also a qualitative phase that happened towards the end of the project around April, and that was part of the research as well. So, a little idea of where this took place. The formative research, as I said, it was a 9-month time period, and it was in 13 different locations in 5 main divisions, which are the larger administrative regions of Bangladesh. So you'll see them highlighted in green there. There's a total of 1,403 subscribers, broken down into 3 main groups: pregnant women, new mothers who are within the first year of their child's birth, and gatekeepers, who again are those husbands, mothers-in-law. And the purpose of the formative phase was really to identify some of the programmatic strategies that were working or that might need to be tweaked in order to guide implementation in the future. But then also, sort of in addition to the program side, the research side was really identifying gaps in the existing M&E system to try and see if we could refine those as the program moved forward. So, talking about the programmatic strategies, there were a number of different things that we were assessing, and first and foremost was looking at effective strategies for enrollment into the program. There were 2 main methods in which people could enroll into the program. They could enroll by themselves, or they could be assisted by a community outreach partner. And so it was looking at sort of how those two different strategies were working. And then looking at effective strategies for promoting the service. If you were enrolling by yourself, you had to find out about it in order to do that. And so looking at some of the popular campaign strategies and whether or not those were working effectively to increase awareness. There was a tiered payment system in Bangladesh, and so they wanted to look at some of the acceptability around those different cost models and how that influenced user satisfaction, as well as satisfaction with the actual message content and with the technology itself, whether it was working as expected. And then finally, to influence whether the program was influencing subscriber knowledge and maternal and child health seeking behaviors. But again, that was of the lowest priority. So this kind of, I think I'll walk you through it, but it shows 2 things. It shows sort of the interaction of a subscriber or sort of the program sort of from where it's managed through to how someone would interact with it, but it also kind of overlays with that what we were interested in testing with the research. And so I think that it's helpful because you can kind of see how the questions map back to the way in which the program was working. So there's 2 organizations that were sort of at the start for this program: DNET, who was the implementing agency, and SSD Tech, who housed a lot of the data on the sending of messages, the receipt of messages. They were a data keeper. And so those 2 interact with each other to some extent to manage the program itself and to manage the data for registration. So then moving on to how they interacted with subscribers, there's 2 different ways in which subscribers could subscribe to the program. self-registration, and that's influenced by the context of a public advertising campaign that raised awareness about Apanjan, and the assisted registration method, which was kind of influenced by the context of various partnerships with outreach organizations who could help to assist people in registering, and also with partnerships with different telephone companies. At the time of the formative phase, there was just one telephone company that was a partner with the program, Grameenphone, and so it was only people who were Grameenphone subscribers that were able to be participants in the program. But that was actually, it's one of the largest, their subscriber base is largely like more of the lower income individuals in the country, so it kind of mapped with the population and sort of the way that the socioeconomic status of the population falls out. And then from registration of pregnant women, new mothers, and gatekeepers, there was a payment algorithm that was applied, and that was largely based on registration data about socioeconomic status. And with that data, there were 3 different tiers of payment that someone could fall into. Either free per their socioeconomic status, they did not have to pay for the messages that they were receiving from the program. And women, mothers, and pregnant women, they received 2 messages per week, whereas the gatekeepers received 1 message per week. Or otherwise discounted messages, where it was 1 taka charged per message, or a paid message, which was about 2 taka per message. And the messages are about a minute. And then there was kind of a 4th tier, which was also paid, but if there was no information about socioeconomic status that was recorded during the enrollment phase, then these were people that were defaulted into the payment tier. So they were kind of there, but it was unknown whether or not they rightly should be there per their socioeconomic status. Now, when someone's enrolled, you assume that they're going to be retained in the program, and if they're retained in the program, then there's the opportunity to change knowledge, behaviors, attitudes, all these different things. So there's a long way to go before you get to sort of that final phase. And what this kind of showed us was there are all these different factors that we're trying to assess, and maybe the scope of the evaluation was quite large because there are so many factors that influence each other down that chain. And so just to map these hypotheses or sort of research questions alongside, we were looking at whether or not enrollment varies by registration mode, so the self-assisted versus the self-assisted, whether or not the partners that were involved in the registration had an effect on the enrollment as well, how the various enrollment strategies like the public campaigns affected registration through self-registration, and then looking at the breakdown of subscribers by payment status and whether or not there was any variation by payment status in retention to the program. What were the various sources that were affecting willingness to pay for the service, knowing that the payment might be different for different people, and looking at whether users were satisfied with the service, figuring that would figure into their retainment. And then finally, this last piece about whether or not it was affecting knowledge and behavior. So here's a little sense of the various different sources of data for the program. There were a number of different sources of data. The primary ones were looking at quantitative data from registration forms and also from qualitative data from structured interviews and quantitative data from the phone surveys. There were a number of waves of phone surveys that were carried out, but the surveys kind of changed. So we used just 2 waves of a 4-wave survey to look at that data. This is, I guess, one chance to kind of mention something that we found that was a challenge to the analysis, and that was that although there are all these different sources of data, there were no unique identifiers that were kind of carried through with all those different sources of data. And so it actually gave us like a moment to reflect and provide some recommendations that DNET has actually already kind of implemented and has changed moving forward, where they have a way to link someone across all of the various data sets and be able to have a fuller picture of their subscriber experience. Okay, so getting into the actual data. So just to give you a little sense of who they were, the subscribers that were in the formative phase, there were 1,403 of them in total, broken down, as you can see here, by the types of pregnant women versus mothers and gatekeepers. And the majority of them had been exposed to the program during this 9-month phase for 6 to 9 months. So really the majority of them were quite familiar with the program during the program itself when they were assessed. Okay, and I won't go through like this whole table, but this is a little bit of an idea of also who these subscribers were. The majority of them were women kind of in the age range of 18 to 34, so reproductive age range. About a quarter of them had a household income, monthly income of 4,000 taka or less, which was about $51 or less per month. And the majority of the women were not heads of household, and over 40% of them said that they had reported less than a primary school education or less. So that actually mapped pretty well to the statistics from the 2011 Bangladesh Demographic and Health Survey, as kind of similar to the national population, which is promising for saying that this is a program that kind of is appealing to the population at large. And this is kind of a continuation of those demographics. The thing that I thought was interesting to point out here was first that about half of the subscribers that were women said they owned a phone, but a little over half of the subscribers that are gatekeepers, these are the mothers-in-law and husband, said that they didn't own their own phone. When someone didn't own their own phone, they might subscribe to the program through a neighbor or family member, maybe someone outside of the household or someone within the household, and it's a shared phone. It makes it so that maybe messages that are sent aren't always received by the actual individual they're meant for, so it's something that we thought was important to consider when we're thinking about impact. And then there were 2 different types of ways someone could receive information through the program. You could get it through an SMS or text message, or you could get it through a voice, like a voice recorded voice thing. Like, I don't remember what IVR stands for, but basically a recorded message. So you could get it one of the 2 ways. And by far, the recorded messages were far more popular of an option. Although this breaks down the demographic information by the different types of subscribers, one of the things that the report also shows is the breakdown between self-registered and assisted registered subscribers. One of the things that's interesting to note is with the self-registered subscribers, they're really characterized by missing data. So when someone was able to register themselves, they didn't necessarily, all they'd have to do is text that they were interested, and they were supposed to be called back to collect some of the information that they didn't necessarily respond to by text. And they weren't always available, they weren't always reached, and so they were subscribed to the program, but very little information was known about them. Okay. And so our first question was looking at whether the enrollment varied by registration mode, and overall 22% of the sample had registered through self-enrollment, and the majority, 78%, had registered with the assistance of an outreach partner. So this shows you sort of that breakdown of self versus assisted registration in the different locations in which the formative research took place. Some of this is a function of the location, like Dhaka is a very urban location, and there was a public campaign that was a little bit more active, and there was kind of the expectation that there would be some self-registration, but there's also a number of different slum locations where they had outreach workers going in that assisted registration also kind of figured in. Khulna was an area where they brought in an outreach partner really towards the end of the formative phase, so there's actually more self-registration there just as a function of that, but overall you see that the largest numbers of participants in the formative phase come from these areas who are in select. And so we also wanted to know about partner-based variation in assisted enrollment, and we took a look at sort of by the different types of people that were enrolled into the program, if there was variation in that. For the most part, it's a similar breakdown in terms of who was enrolled by different partners, but one of the things you can kind of see by the sample sizes is that Mahoney and BRAC were really the most active in enrolling participants into the program. And a little bit of this is a function of the fact that DNET provided targets for people to, for the organizations in terms of how many to enroll. So some portion of this is driven by the fact that they had higher targets to reach. And there were different numbers of community health workers trained and engaged in the program for the different organizations. But field notes from DNET suggest that there was a little bit of a difference in terms of the level of buy-in by organization, and that might have affected some of this as well, as like a need they found for refresher trainings to make sure that people were familiar with all of the different ways in which they had to collect data and report interest in the program and registration data. And so this kind of helped to understand how to improve data quality once you looked at partner-based enrollment. Again, looking at missing data here, there was overall an issue with completeness of particularly the socioeconomic status data. It ranged from 51% to about 64% that were complete data files for various people enrolled in the program. So there was a fair number of registrants across these different partners who did not have complete socioeconomic status data, and that was really critical in determining your payment status in the program. So it's an important factor to think about. So this tells you a little bit more of the story of partner-based variation in enrollment. Assisted enrollment was a really effective strategy for being able to build upon existing community familiarity with the health workers as well as trust in them. And this woman subscriber kind of exemplifies that in her quote. She said that you should really give those leaflets to health workers like Ruby Appa, which is sort of a term of respect in Bangladesh, because they're the people that will be able to reach her, she's saying. But on the other hand, for the community health workers, there's a sense of pressure to incorporate MAMA into their existing kind of scope of work, which was already quite busy and burdensome. And so this community health worker in Sylhet was saying she has to travel long distances and she incurs travel costs. And in order to fulfill her target of 18 forms, she has to travel long distances, and that's going to incur some physical stress as well as conveyance bills. So there's a challenge that that the community health workers were facing in trying to be committed to the MAMA program. And one of them mentioned if Panjin gave us travel allowances and mobile costs, that they covered the mobile cost, then we could do the work easily. We're working here, but hardly getting any recognition. So this really kind of helps to think about how to continue to engage community health workers in the program and make sure that they're sustained in terms of their motivation to enroll people into the program. So next we wanted to understand for self-enrollment how the public campaign was affecting and driving enrollment. Although just 22% of the sample had enrolled through these self-enrollment, through that self-enrollment mode, we wanted to see if the various strategies were affecting their enrollment differently. And this was a little bit tricky to tease out, but just to give you a sense of the different types of enrollment strategies, the campaign strategies include leaflets, audio broadcasting through vehicles that move throughout communities, posters, arrangements with hospitals and clinics that someone be seated in the waiting area and kind of be able to talk to people about the program. And then in just a few places, a community meeting that also allowed people to become more familiar with the program. So there's a variety of campaign strategies that were employed, but the way that they were tested in terms of their effectiveness was through this phone survey that listed just a few and asked people if they had learned about MAMA through these types of methods. And we found that really very few reported that this was something that they had heard about when they were applying. So just about 2 to 5% reported any awareness of the campaign, the popular campaign methods. Again, there's some limitations with that in that this assessed people, but it didn't look at whether or not they were the method through which they were enrolled. So we don't know if looking at just the self-enrolled might have boosted these numbers, or if there was a different way of asking that question that might have changed those numbers, but it seems like the awareness of that public campaign was rather low. So next, we wanted to look at the breakdown of the different payments tiers, the payment status tiers. So this gives you a little sense of how the payment algorithm was applied through DNET. They had a partnership with BRAC, one of the outreach partners, in which BRAC had agreed that they would help to enroll participants, but all their participants that they enrolled would be free. So if the subscriber was a sister of BRAC, they had a free payment status. If then the pregnant woman was a new mother and head of the household, she was also assigned free status. If the pregnant woman or new mother had a primary school education or less, again, she had free enrollment status. But if not, and her household family income was less than 4,000 taka per month, she received discounted status, so the 1 taka per month rather than 2. If none of this information applied to a woman, then she would be assigned full payment status, about 2 taka per month or per message. There are some exceptions to these rules that we noticed in the data, some ways in which this algorithm did not seem to apply. But for the most part, this was the algorithm that DNET was supposed to follow in assigning payment status. So looking at that, kind of wonder whether or not, or what the breakdown looks like. In general, the breakdown looked like about 57% were assigned a paid status. 57% assigned a paid status. About a quarter were at discounted status, and 17% in this free status. But in this 57%, we can approximate that there's some amount that were kind of defaulted into that payment status, and we think that about 276 out of the 792 that were in that category, or approximately 35%, were defaulted into there, and that really does possibly play a role in terms of user satisfaction. So it's important to kind of think about, again, that missing data quandary that they faced during the formative phase. But overall, when it came to acceptance of the cost models, participants were relatively accepting. This was kind of assessed in 2 different ways, though, and so I think that it kind of speaks to another research issue of timing of questions, especially for something that's a new service that you might not have experienced before. At registration, people were asked how much they would want to pay for the service, and if you look down here at whether people are willing to pay 2 taka, which is the full price per message, the majority, about 67%, 63% of women said, yeah, I would be willing to pay 2 taka per message. This is before they've ever received the messages. So they might have been demonstrated the messages through a community health worker, but they didn't actually know what it was like to receive them in their daily life. Whereas, once they had been receiving the messages and they were assessed again during a phone survey that was later on in their enrollment, that kind of shifted. And so you see here that among the women and mothers, although it's a small sample of just 54 people, about 60% say they'd rather pay 1 taka or less per message. And so you can kind of see that, like, these attitudes, they might shift once you actually experience the program and you know sort of whether or not you're going to receive the messages, whether those messages fit with what you were expecting, all those different pieces. The gatekeepers were actually quite a bit different in terms of what they were willing to pay, and so they were a bit higher on the willingness to pay scale of being willing to pay, kind of around 2 taka or 1 taka per message. So then, thinking about user satisfaction, one of the other things that we wanted to think about was just in general whether or not people were satisfied with the service, and really almost everyone, 94%, said that they were generally satisfied with the service. But and someone said, I got aware of these things, talking about at Panjan. Now I'll tell 10 more people about the service and they'll get to know about it. Cost was really a driver of user satisfaction, and it was something that we saw come out in the qualitative data as well. So one of the things that people voiced dissatisfaction with was the kind of irregularity of when the cost for a message would be subtracted from their mobile account, or when it would be credited back. If they had a discounted status, they would be charged the full amount but then credited an amount later. And so that was something that I think threw people off a little bit. One person said, they take a big amount of money. Sometimes I saw suddenly that there's no balance in my phone. If the service charges 50 paisa per message, then it'd be better. Looking in general at user satisfaction as well, the number of subscribers that deregistered for the program was actually very low during the formative phase. During these 9 months, just 18 people deregistered from the program. And if we kind of looked at kind of continuing with that data through June 30th, 2013, so allowing people to kind of continue on after the formative phase, it bumped up a little bit so that there were a total of 30, 40, 50, 61 people that were deregistered from the program by that point. But this is something that either was like a rare phenomenon, so we would need a lot larger sample size to look at deregistration, or just that short time period of 9 months might have kind of been too short to kind of capture the deregistration. So it's something that if you wanted to explore a little bit more what drives someone to deregister, what kind of drives dissatisfaction with service, you probably need a little bit larger sample to really explore. In terms of the message content, there was pretty large satisfaction with the content, but there were some areas for attention. Specifically, there was an interest in messages about maternal and child health and nutrition specifically, and then a desire for something that was more interactive, maybe being able to talk to a doctor over the phone or to be able to ask questions and get responses, so something that was a little bit more interactive than they were receiving. And in terms of the technology and its actual performance, again, people were generally receiving the right number of messages, but there were some inconsistencies in the time the messages were delivered, or they weren't necessarily delivered on the same date. So people didn't have a way of kind of building these routinely into their lives, and that could kind of create difficulties for people. And again, about the reimbursement of the messages. In terms of influence on knowledge and health-seeking behaviors, this was really something that couldn't be assessed during this phase of the program. There were some ways in which qualitatively we kind of got a sense of people's influence, the way that their actions were influenced by the program, but it was pretty limited in terms of the data that we could work with. And again, it wasn't really as much of a priority for this phase. So for the way forward, I think I'll try and kind of stick to this briefly, but maybe if we have some time for questions, we can talk about it. There's a number of different ways in which the research design could really be changed, and this is within the report. There's a large section that kind of focuses on some of these ways to build in a control arm or a comparison arm, demonstrate the impact of the program as well as the sustained impact over longer periods of time, understand these rare phenomena like deregistration, get deeper insight into the user experience through more open-ended questions and the qualitative methodologies, and looking at sort of the sampling frame and sampling methods and who you're really trying to generalize the study out to. Data management, things like the way in which data quality is monitored, as well as the way in which the DNet and SSD tech, who houses the data, can interact with each other, was something that we discussed as well, because it could provide a lot of rich data for how you could look at user satisfaction and satisfaction with specific types of messages. And validity of some of the variables, like in terms of making sure you're measuring what you want to measure. So with payment status, whether or not someone understands the payment status model before you ask them about whether or not they are satisfied with it. The phone surveys, they adjusted the instrument midstream, and that really does affect what type of data you can use from there or what you can pull from. And the way in which questions are phrased and ordered kind of affects whether or not you can feel confident in the data that came out from there. And finally, this is a new program, and so for the variety of number of countries and organizations that are trying to adopt some version of it, it's really helpful to have sort of a process documentation framework. So some way of documenting all the different decisions that went into the evolution of the program is really helpful for other organizations that might want to adopt a similar type. And programmatically, there are a lot of these changes that DNET actually has already implemented to date. Emphasis on the brand name of Apanjan was something that kind of came out through the qualitative data that people didn't necessarily remember the name Apanjan, but they remembered the phone number. So kind of putting more emphasis on that, making sure that you engage with the community outreach partners, with call center agents, the DNET staff to boost data quality by kind of refreshing people on the different processes that they need to be involved with, linking data sets through unique identifiers, pre-testing instruments, developing a proactive system for interacting with SSD tech to look at some of those message metrics, and then finally setting a regular schedule for sending messages out so that people know when to expect them. And this is finally just a little bit of a snapshot of the wide variety of ways in which this research could kind of move forward. So thinking about all the different inputs that the program puts into running, sort of at the national level, as well as down to the programmatic level, through to the way in which it's trying to impact the program. This kind of gives you like a great map of all of the different ways in which you can look at different ways that impact might be affected and ways to kind of carry research forward in the future. So I just had a couple of acknowledgements. There were a number of people that we worked with for this report at DNET as well as at Hopkins and USAID Bangladesh and CHIP, as well as the participants in the study itself. So with that, I'll just say thank you. And maybe we could go ahead and take questions at a time.
I think we're okay. We just maybe have 15 minutes.
Okay. Should we maybe just get into questions?
Yeah,
and we can
sure,
just kind
yeah.
of talk about Mama Broadband. Anyone's interested in?
And you want me to? I'll just hand these out.
Oh yeah, we've only got a couple.
Sure. Sure.
Yeah.
Only if you're really interested.
First of all, thank you so much for the presentation. It was really cool to see that. So I have a question about the cost per message. So it seems that people thought that maybe they didn't want to pay so much for the cost, and I'm just wondering what the purpose of it was, if it was like the deal you made with the telecom companies, or if it was like trying to make it sustainable, and how much that actually contributes to the sustainability of the project.
So I can talk about that a little, and then maybe you guys can step in. But part of it was this interest in sustainability of the project, but also in kind of looking at a way to I think a way to kind of self-sustain the program in time, that the paid subscribers would be able to sort of subsidize the free subscribers, and so that cost model was to try and kind of make sure that this program didn't have to rely on outside donor funding for its life.
Yeah, I would support that. I think one of the things that's interesting about Apanjan compared to some of the other MAMA countries is that they have subscribers that are like urban, university-educated women who are willing to pay more in order to kind of cross-subsidize, and they haven't been able to kind of get the numbers in order to really generate enough revenue from that group. But I think that's kind of their long-term goal, is along the sustainability and kind of tapping into the diversity of willingness to pay.
And I mean, it speaks to an interesting sort of potential for trying to dichotomize the way that you attract subscribers, because I mean, if some of them are supposed to self-subscribe and they might be kind of not necessarily interacting with community health workers as often because they're at like a socioeconomic status where that's just not part of their routine, then maybe the ways in which you kind of attract the paying population are different than the ways you attract the non-paying, or the ones that are less likely to be subsidized.
I would say that conversation sounds a lot like the debt the death spiral concerns for the ACA, trying to pull in the youthful population so that we don't have too many sick people. To go on your comment, you may or may not want to look at certain health insurance strategies and clearly you're marketing differently, but the ways they try to tailor the information, and I don't know if it'll help guide you or not, but just know.
I mean, just to build on that, I think I was just thinking that there really is no differentiating content between a paid and a free subscription, right? So in some areas they've tried, freemium approaches where someone who pays gets added benefits, and that helps make the value for that payment worth more. And then those who don't pay get sort of a pared down version of that still has good content, but does not necessarily have all the bells and whistles that you would with the paid version.
So every year they do kind of a larger sample survey in households, and they ask a lot of questions around the dialect and if people are happy with it and comfortable with it. And one of the things they found is that the kind of higher educated people prefer a different dialect than the women living in the slums, so they're now developing kind of two. It's not really the amount of content or information, it's just the way it's delivered.
Right.
And yeah.
We have one question.
I actually have two questions. So that was really great, especially since I actually subscribed to the program while I was in Bangladesh this last year, and I had some issues with it at first because I subscribed as a self-subscriber and didn't get my messages for about 2 weeks. So I was kind of surprised when they started coming, and they were very irregular. I'd get them at really odd hours. And I vaguely remember there being an option to call and have and listen to a recording and not have it kind of appear on your phone, but calling yourself. And I wondered if you had broken down the results at all to see if there was a difference between people who elected to call themselves to receive the message versus were called.
So you're correct in saying that there were sort of those options, and we didn't have the information about people who had called in order to really explore it. There was, I think from the qualitative data, a little bit of a lower awareness of the fact that you could kind of call the call center, call some of these other options to hear and to have the message repeated to you, or have a chance to hear it again, or hear the message without having it call you directly. So I don't think that people were as aware of that, or kind of had been as in tune to the fact that that was an option for them.
And I think that's true still, that a lot of people just don't know about that, and there's very few people that actually use that.
Right, because the only place that I saw it online was the breakdown online that showed the flowchart of your options. And then my second question was, given that people seem to want more of an interactive interface, have you thought, or has there been any discussion about partnering with something like Grameen Phone that has Helpline?
Yeah, so they actually added, was it last spring? I'm losing track of time. Last spring, they added in a call center where subscribers can call in and speak to an actual doctor. And the doctors can then refer them to local clinics or hospitals if they're presenting serious symptoms. So that was a feature that was added in direct response to the fact that women said that they wanted to be able to talk to a doctor at times. So, yeah.
Could you talk a little bit more about, because I saw that there were YouTubers, pregnant moms and new moms, and I was wondering, is it customized and the frequency of when and how they would receive the messages? Is it over time? Like when they enroll, do they know how much in total they'll be spending on these messages?
So there's a couple of things that are interesting to kind of talk about within there. So the way in which the messages kind of are customized is that when, let's say, someone is assisted into enrollment, they have to report sort of where they are in terms of gestational age, and so then the messages are supposed to be stage-based. So you're supposed to apply if you're at sort of 7 months pregnancy versus if you're at 3 months pregnancy, and kind of make sure that they're relevant to you in that way. But then, and once you roll over from being a pregnant mother to a new mother, the community health workers might be able to kind of assist in making sure that that rollover is kind of timed correctly. But then you're supposed to receive messages that kind of talk about the mother as well as the child, and postnatal care visits, all those different things that are kind of more related to your life as a new mother. But in terms of sort of the payment expectation, I think that there wasn't as clear of an expectation of how much you might pay, and that can really vary depending on whether it's just the woman who's a subscriber, if it's a woman and the gatekeeper, if they're like receiving messages kind of from the start. I think it was around 3 months is around the start of when people might be enrolled into the program, 3 months of pregnancy. Or if you're starting out as 1 month into being a mother, that's a different length of time and overall amount that you'd be paid, that you'd be paying for the service if you're a paid subscriber. So there was a lot of variation in terms of sort of what that would look like. And although the outreach partners are supposed to talk people through that, I don't know if they broke that down as clearly, because in the qualitative data we did hear a little bit of feedback about being surprised that they were a subscriber or not really being so clear on the payment model. Do you guys know?
Yeah, I was just going to add to that. I was in Bangladesh in March, and we went out with a BRAC community health worker and visited some families. And one of the things I realized is that when a BRAC health worker is introducing the family to the service, they introduce it as part of BRAC. And so, there was the point about recognizing Apanjan as, so for all the BRAC subscribers, they don't know it as Apanjan, they only know it as BRAC. So there's things like that, and then there's also a lot of variation in the kind of people that the outreach partners will use as community health workers. So they have different kind of standards of education that are required, and therefore it makes the trainings really difficult, because so they've tried kind of skimming back, I think, on some of the outreach partners that are using people with lower education levels and everything, because they just, the payment algorithm and it just gets really complicated, and they were finding it hard to standardize what was being communicated to subscribers, and yeah.
I mean, to go off on that, if they didn't find it helpful, how easy was it to unsubscribe? Or was that complicated as well? That you imagine?
So unsubscribing, I don't, because there were so few people who deregistered, it wasn't something that came up in the data, but the process of it was calling the call center and just saying that you wanted to unsubscribe. The fact that 18 people deregistered, I don't know if that speaks to the fact that it was like unknown how to unsubscribe, or if people were truly satisfied, given that 94% of the sample said they were. Yeah, or right, like people were just, that's fine, now I get these messages, yeah. I know, being in India, like when I've had a cell phone there, I just suddenly get all these text messages. I don't know where they're coming from. I don't know how to subscribe from any of them, so I just let them come in. So it could be that too.
Going on something that Josie was saying, so in terms of customizing the messages for people of higher versus lower socioeconomic status, I was just wondering how you're going to do that if people aren't really reporting their status. Because Radha, you were saying that that was some data that you didn't really get.
Yeah, so I mean, what I can say is that kind of from both the self-register as well as the assisted registration, that missing data was an issue that came up both ways. But with the assisted registration, through trainings and kind of through greater engagement with those outreach partners, you might be able to kind of boost that data quality. With the self-registration subscribers, it's tough because if they register, then you don't want to not give them the program, even if you can't call them back and gather all of that information. But
yeah, so what happens now is you can call the short code, and it gives you an option, like, do you want to register yourself and you just follow the prompts, or you can ask to speak to an operator, and then a call center agent will register you through. And when they do that, that's working much better. They're getting a lot more, they're getting better data, more complete. The problem is those following the voice prompts still. That's where, they're just not following it all the way through.
And something I learned recently, while the content doesn't differ based on your socioeconomic status, it's very different for urban versus rural contexts. So for example, in urban settings, it will say go to your hospital, not go to your clinic, or talk to your doctor, not talk to your community health worker. There are messages about diapers, disposable diapers, and car seats, and taking time off from work. So they do cater to rural versus urban settings. So I would imagine that even a woman in an urban setting who's maybe a little bit lower income hospital would resonate more than local rural clinic would. You know what I mean?
Interesting. In South Africa, they've got at least 6 different language options.
Yeah.
And I can imagine someone saying, "Do you want fancy Bangla or do you want?"
Exactly, that's it.
You know?
Yeah.
One other question, yeah.
Well, I was just going to ask how you decided on the 4,000 taka threshold, and whether that varies based on rural and urban, because I could picture rural, that would maybe be a large chunk of change, but in urban areas that might not be that much. But I don't know much about it,
So I actually don't know as much about the 4,000 taka threshold and how that was decided upon, but I know that the one thing that I didn't mention within the socioeconomic status criteria that was a fourth criteria was actually the occupation of the person. So if they were a farmer or there were a few other occupations that were identified, that was also something that was considered within socioeconomic status to kind of determine payment. I think that maybe there was some corresponding relationship sort of between like what the expected income of some of those occupations might be and how that would affect like your ability to afford the expenses that you need for getting by and living.
Yeah, one of the things that DNET's been doing since the formative research came out is offering blanket free subscriptions to certain specific areas that they know are really ultra poor due to the incomplete forms. And so in addition to really boosting the training for the community health workers, and they also introduced brand promoters whose sole purpose is to sign women up for the Apanjon service so they're not overwhelmed by a portfolio of other services that they have to provide. They're incentivized to just sign women up to Apanjon, but in addition, this blanketing the free service, I think, is a way that they've decided to kind of cope with issues around identifying who can pay what and issues with incomplete registration data.
I think we probably only have time for one more, but
Someone has something insightful to say, I would go with that. Mine was just a suggestion.
that's probably insightful. Happy to hear it.
I was thinking about something that we have an issue around here is minutes on phones. I don't know how it works over there, but if someone is really tight on minutes or doesn't see the cost of even a 1-minute phone call to unsubscribe or to get the voicemail message or whatever to be worth it, they may not, that might be one of the reasons for a lack of uptake on that intervention. I don't know how that factors in for you guys or not, but if we're having a problem with a relative, in my opinion, a relatively reasonably priced text message, voice content tends to be more expensive, or at least has greater value, so that may or may not be an issue. I don't know if that makes sense.
No, I think it's a good point, and one that some deployments of both Mama and other text message services have used what they call a flashing, or in some countries it's called PCM, please call me. So a lot of MNOs, network operators, actually allow you to send a missed call to a number, or the 3 letters PCM, please call me, for free. That indicates I don't have enough minutes, but I'd really like you to initiate the call. And so I mean, that might be a way that you could have that. The subscriber could initiate a missed call to a number that would then trigger a callback.
Exactly,
and
call center to call back.
And I forget, there's like 3 different charging structures. I put this in a footnote recently, and I wish I could see it. But I know that in certain cases with certain MNOs, if you're pushing out the message, the charges only go to like SSD Tech, for example, to whoever's pushing out the message, not to the recipient.
Yeah.
So it depends
Yeah.
on the.
Right, because in Bangladesh, you don't pay to receive, even in South Africa, you don't
Yeah,
pay to receive
exactly.
a call, but yet they pay for the service.
Exactly.
So it's something that people are used to, receiving a call and money going
And
out.
paying
Yeah.
money. Well, anyway, thank you so much, Radha, and thank you everyone for